time, I'll go ahead and get us started. So good afternoon, good morning, depending on where you're coming from today. My name is Jordan Greenwald. I'm the Training and Community Engagement Manager at Healthcare Education and Training, and I will be moderating the webinar today. So first, I'd like to briefly introduce you to HCET in case you're unfamiliar with us. So our mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. We are an organization of passionate people who are proactive in our belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. This webinar does have closed captions available. To enable them on your screen, you'll either click live transcript or show captions, depending on what version of Zoom you have. So to open those, you'll just click show subtitles or show captions, and then you can also change the settings by clicking subtitle settings. Throughout the presentation, we also encourage you to send your questions via the Q&A box. So to submit a question, you'll hover over the main screen, then select the Q&A icon at the bottom. Once selected, the Q&A box should appear. And to send a question at any time during the presentation, please just send it through the Q&A, as this ensures everyone in the webinar can view your question. And then questions can also be sent anonymously if you choose. Please be sure to also follow us on our various social media accounts to keep up to date with the newest information and events. Now I'll just quickly review some housekeeping information. So a link to complete an event eval will be sent to you in the chat at the end of the webinar, as well as via email following this event. Your feedback is greatly appreciated as we use it to inform future events, so please fill that out for us. Archived presentations and a list of upcoming events can be viewed on our website, hcet.org. And if you have any technical difficulties during this presentation, please contact either myself through the chat, or you can email updates@hcet.org. Nursing contact hours are available for this webinar. So in order to receive those, you must attend the entire webinar, return the completed participant evaluation, and then send that nursing contact hour form, which we will send after this webinar, to kbradford@hcet.org. No one with the ability to control content of this activity has a relevant financial relationship to disclose within an eligible company. And now I'd like to introduce you to your presenter for today. Dr. Kara Berg-Ronick, a nurse practitioner, is the Director of Clinical Quality at Healthcare Education and Training, where her work focuses on improving reproductive and sexual health and adolescent health outcomes throughout the Midwest, and where she is honored to serve as the Director of HCET's newly launched Midwest Trauma-Informed Training Center. She maintains a clinical practice through Path4U, Indiana's statewide contraceptive access project. Using and advocating a trauma-informed approach has been central to her philosophy of care since early in her career, when she worked as a certified sexual assault nurse examiner at the Cleveland Clinic. Kara is a past president of the Indiana chapter of the International Association for Forensic Nurses and currently serves as the lead for the Indiana Perinatal Quality Improvement Collaborative's Trauma-Informed Care Subcommittee. She teaches frequently in community, academic, and professional settings on various sexual health and trauma-informed topics. Without further ado, I will be turning things over to Kara.
Okay, thanks so much, Jordan. And thanks, Marika, for getting us set up on this adventure today. So before we sort of dive right in, I also wanted to just take a second to talk a little bit about the Midwest Trauma-Informed Training Center. So as Jordan mentioned, HCET launched MTITC in response to community need, and we make in-person virtual training, resources, and technical assistance in trauma-informed care available across the Midwest. Our North Star, our sort of guiding vision, is to transform the landscape of health and human services by equipping professionals with the knowledge, skills, and support to provide trauma-informed care as the standard practice for all. Again, thank you for joining us today. It's also weird to talk while my face is on the screen, but like, what can you do? Okay, so again, no conflicts of interest. You heard about HCT, and we are thrilled to be partnered with the Indiana Department of Health this year to support their learning collaborative focused on trauma-informed care. So this webinar is brought to you as part of that series. Okay, so here are our objectives for the day. And while you're sort of taking this in for a second, I just want to, of course, start with a message that talking about trauma and trauma-informed care can really be challenging or activating for some folks. We're actually going to discuss how and why that happens later in the talk. But please do what you need to do to take care of yourself today through this session, especially if anything feels uncomfortable for you. So we fully respect if you need to step away or again, come back to this. You'll have a recording. You can come back to it at a later or better time. Okay. So we're going to start with trauma. So in order to really dive into trauma-informed care, we have to understand what trauma itself is, right? And trauma can be defined many, many ways by many different people and organizations, but the sort of definition that we use here is from the Substance Abuse and Mental Health Services Administration, or SAMHSA. And they define trauma as something that results from an event or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting effects on the individual's functioning and well-being. It has also been defined commonly by people as something that overwhelms a person's ability to cope. So I like to keep that piece in mind as well. You can see here on this screen the three bolded terms, sometimes referred to as the 3 E's. So events, experiences, and effects. So looking at those 3 E's, really experience is key. And what we mean by that is that it is the individual who decides if a given experience is traumatic or not. The same event can be experienced by one person as traumatic and not at all traumatic by another, right? So my background, my clinical background is in OBGYN, right? So one of the classic examples in our world is the experience of a C-section, right? So to one person, this a C-section might just be one of 2 ways a baby can come out, right? Neither positive nor negative, just kind of one of the ways, not a huge deal. For another person, a C-section could be actively empowering, right? Something that is scheduled, planned, controlled, and actively desired, right? And yet for another, it could feel truly catastrophic. Perceived as a failure of the person's body or goals or self-image, and experienced for that person as a significant trauma, and a trauma that maybe they're reminded of every time they look at their body in the mirror or go to see a healthcare provider in the future, right? A different example would be thinking about maybe children who are removed from an abusive home. Where for one sibling might feel relief in spite of the disruption and stress, right? But knowing that they're moving to a safer environment. And for the other, in spite of now being safer, they may be traumatized by the disruption in their family and their normal routine and familiar surroundings, right? So same family, same event, but very different experience. So trauma can be broken down further into additional categories. So some trauma, and this is usually what we kind of think of when we first think about trauma, is acute. So this is, think like a one-time event, like a natural disaster or a one-time sexual assault. Some trauma is chronic or complex. And here we'd be thinking about things like witnessing or experiencing domestic violence, loving someone with or living with a substance use disorder, experiencing human trafficking is an example of complex trauma, and then living unhoused, another good example of chronic trauma. So we know that traumatic experiences can primarily affect one individual and maybe extend out to his or her family. So think about kind of the ripple effects if someone is in a car accident, right? Or experiences, again, a sexual or physical assault, or even a severe illness. It can also occur within the context of a group. So here we're thinking about maybe trauma experienced by first responders, right? Or those who have seen military combat. Or it can happen within a community. So here we're thinking about things like gang-related shootings, things like that. It can also transpire within a certain culture, such as mass shootings within a synagogue or church or queer bar. We could also see things like large-scale disaster, so like a hurricane or a terrorist attack, right? So again, lots and lots of different ways that we can think about trauma. So we are going to spend a few additional minutes talking about the concept of historical trauma. So historical trauma reflects systemic oppression and systematic oppression of a particular group across generations. This could include genocide, slavery, police brutality, forced relocation. I myself am a grandchild of Holocaust survivors, and we certainly feel this within my own family. So our patients and clients are often bringing a well-earned historical mistrust to the healthcare system and into our interactions with them. A lot of the examples that I have today are based, again, sort of in my world of GYN, but I would invite you to think about examples in kind of your primary care settings or in whatever setting you work in, and please feel free to add them to the chat if you'd like. So in gynecology, a couple of specific examples include J. Marion Sims, right? He is considered the father of gynecology and even had this statue erected of him in New York City. It has since been removed. Sims invented the speculum and developed all kinds of surgical techniques that are still used today and are really important in modern medicine. However, he did this by experimenting on enslaved Black women. You may have seen this painting before, which shows Dr. Sims in Anarcha, who is an enslaved Black woman who was just 17 when she had her first baby. And Dr. Sims performed 30 non-consensual surgeries on her. He didn't use anesthesia, even though it had recently become available. And at the time, people believed that Black women did not feel as much pain as white women. And in fact, we have to acknowledge, regardless of specialty, that this myth persists today, right? It is well documented in the literature that Black people receive statistically less pain medication than white people do during hospitalizations and after surgery. This legacy of violence and historical and intergenerational trauma continues in our society, truly with more examples than we can count. So from Henrietta Lacks, a Black woman who in 1951 had her cells taken during cancer treatment without her knowledge or her consent for use in medical research, also without any compensation for her or her family. Or we can think about the history of the pill, where clinical trials were done in the 1950s on Puerto Rican women without being told that they were in a trial or about any of the potential risks involved, to our country's history of and ongoing instances of coerced or involuntary sterilization, to Tuskegee, where Black men were followed, whoops, sorry, just kidding, got excited, where Black men were followed for 40 years to see the progression of syphilis. And this continued after the treatment for syphilis was available. It wasn't offered to them. And this, of course, was done without their consent. Those 40 years, y'all, were 1932 to 1972. And 1972 is just not that long ago, right? So we can see this legacy of racism and classism throughout the history of healthcare. Just as one example we can look at today is thinking about, if you look at a map of where hospitals open and close today, we can see some of these dynamics at work, right? And we all certainly witnessed the ramifications of this history as we lived through and experienced COVID together, right? So again, perhaps you can think of other examples within your specific areas of care. And if you have anything that you would like to add to the chat to lift up as other examples, that would be great and welcomed. So at baseline, regardless of area, regardless of practice, all of this has sown distrust throughout our system, throughout the healthcare system. And we know that this kind of systems level trauma and historical trauma enters our encounters every single day in healthcare and in life. Okay. So we've covered events and experience, but what about effects? This brings us to the ACE study, which hopefully many of you have heard. I know the folks from our Learning Collaborative have heard about the ACEs, but I do want to give just a little bit of background and refresher. So ACEs are traumatic events that occur in childhood. So in 1998, Kaiser Permanente, along with the CDC, did a landmark study that looked at 10 categories of childhood adversity that they found to be particularly impactful to long-term health. So this study found that there were experiences that were linked to really a cascade of adverse health effects and outcomes, and that the more categories of ACEs a child experienced, the more likely they were to experience these outcomes. So again, it was kind of a dose-response relationship. They didn't look at severity or frequency of these occurrences, but just sort of a like plus minus, have you experienced this category, yes or no? And again, the more categories that were touched on, the more likely they were to have these negative outcomes. So one thing that we do need to note about this study is that participants in this study were largely white, largely middle class, and highly educated. A more recent Philadelphia ACE study focused on a more diverse and urban population, and it really focused on community level adversity and how that could impact health outcomes. So they ultimately found these 5 additional ACEs that are noted here in the dark blue circles. So these included living in foster care, feeling discriminated against, experiencing bullying, witnessing violence, and experiencing adverse neighborhood events. Okay, so we've got our abuse categories, neglect categories, these household dysfunction categories, and then these community categories. Okay. Now we know that ACEs are incredibly common. From the original 10, 64% of people have at least one ACE, and 12.5% have 4 or more. So this is a brief video that discusses ACEs in a bit more depth. You'll hear from the original researchers here as well as a few others. Jordan, just throw me a thumbs up to make sure that we're hearing when I press play, but you should be. Here we go.
Rob and Vince then began a collaboration that's ultimately become one of the foremost epidemiologic studies of the long-term health impacts of child abuse and neglect.
I think the most important thing that contributes to the information of the ACE study is simply the powerful nature of when people tell you the truth about their lives and you listen, you understand their life course.
It's made me realize how much of what we see in adult medicine is the result of what was present but not seen in pediatrics.
ACE has changed the landscape, and I want to talk a little bit about how and why they changed the landscape and how we can take what we've learned from the ACEs.
It's just not a social worker's problem. It's just not a psychologist's problem. It's not a pediatrician's problem. It's not a juvenile court judge's problem. It's everybody's.
It changed the landscape because of the pervasiveness of the ACEs, the huge number of public health problems, expensive public health problems, depression, substance abuse, sexually transmitted diseases, cancer, heart disease, chronic lung disease, diabetes.
As the ACE score goes up, the likelihood of chronic, self-acknowledged chronic depression goes up, so that at ACE score 4 or higher, you're bumping a prevalence of 60%, 60% in women, and about 35% in men.
This is the percentage of people that ever smoked cigarettes, and here's the percentage of current smokers. We could switch the titles on these slides now. You wouldn't know which was from the Kaiser Health Plan and which was a general population sample in Washington.
So how do those people, without the conventional risk factors, end up with coronary disease? We have used this over an 8-year period with 440,000 adult patients.
I believe that this is the most important thing you can ever do, which is begin to deal with this intergenerational transmission of adversity that causes so many problems in our society.
Okay. So hopefully that was valuable. I always like hearing from Dr. Felitti and Dr. Anda directly. So as you saw in this video, the more ACEs a person has experienced, the more likely they are to have any of these health outcomes, right? So people who have experienced 4 or more ACEs are 12 times more likely to have attempted suicide, 7 times more likely to abuse alcohol, and 10 times more likely to have injected street drugs. There was even a recent study out of Wales that showed the more ACEs a person had experienced, the more likely they were to decline the COVID vaccine. So not only personal health outcomes, but also public health outcomes that matter to us. So I'm based in Indiana, and here nearly half of Hoosier children have experienced 1 or more ACE. And in fact, Hoosier youth have a higher prevalence than their peers nationally in 8 of the ACE categories as measured by the National Survey of Children's Health. So remembering that 1 in 8 people had an ACE score of 4 or more, this means that anyone who sees or interacts with at least 10 people a day probably sees several people who have themselves high ACE scores, right? Who are carrying a history of adversity and trauma with them. So ACEs can have long-standing negative impact on our health, but why, right? One of the proposed mechanisms for this is through toxic stress. So we know that not all stress is bad, right? Some stress is healthy and positive. It prepares us to respond to temporary challenges in our lives, like running a race or starting a new job or public speaking. And when these events occur, our stress response activates and then quickly returns to baseline. So more intense or longer lasting stressors can still be tolerable if we have supports in place in our lives to help us cope. Remember, we said that trauma was something that exceeded our ability to cope, right? If we don't have supports, then severe or frequent exposure to certain types of stress can have a toxic effect on the brain and body. And Dr. Nadine Burke-Harris, who is California's first Surgeon General, has a great analogy for when positive stress and even tolerable stress can become toxic stress that I'm going to share today. So imagine with me, just a brief visualization here, that you are walking through a forest. It's beautiful, the sun's shining, the birds are chirping, everything is fine. And all of a sudden you hear a twig crack and you look behind you and you see a bear. Your body has a reaction in that moment, right? You release lots of hormones, adrenaline and cortisol and all of this that's getting your body ready for fight or flight or freeze, right? You're going to fight the bear or run from the bear or drop and play dead and hope the bear ignores you, right? That fight or flight response. And when you have that response, if it happens only once in a while, it's really protective, right? I don't actually think that I would be very successful in running from a bear or fighting a bear, but maybe you would be, right? It can save your life, right? It activates you enough that you're able to respond appropriately to the bear in that instance, right? And normally that reaction happens, that fight or flight happens. You escape the stressor, the bear does leave you alone. You return home and you have this great story, right? Those hormones leave your body, and you go home and you tell all your people what just happened out to you in the woods, right? But now imagine, if you will, what happens if instead of that bear follows you home and moves in with you, right? What kind of reaction do you have now? What happens in your brain when you are faced with that level of stress day in, day out, every day? Our bodies simply aren't built to be in fight or flight all the time. So we're going to talk a little bit about what actually happens in your brain when the bear is living in your house. So a sustained activation of the body's stress response, like that analogy, physically impacts many of the brain's functions. So there's a pathway in the brain that secretes hormones that actually gets dysregulated. And the part of the brain that regulates memory and learning actually shrinks. The areas of the brain that regulate thoughts and emotions also shrink. And the part of the brain that connects emotions to many other brain abilities like memory, learning, and our senses gets bigger. The part of the brain that takes in information from experiences and turns that into how we understand the relevance of situations and how to respond appropriately actually begins to lose its ability to respond. Then you add in those stress hormones. We talked about cortisol and adrenaline from the chronically activated fight or flight. And when you pair that with this chronic stress, you get inflammation, which causes all manner of ill health and makes it hard to function. So here's a question. Have you ever looked at someone and thought any of these words? Have you ever been called any of these words, right? Next time you look at someone and think any of these: lazy, disorganized, forgetful, absent-minded, scatterbrained. Think about what might be going on behind the scenes in their lives, right? We know that these changes in the brain are also the source of what we know as coping mechanisms. So coping mechanisms are personalized strategies that allow people to function in their daily lives in the face of past or ongoing trauma. And these activities or mechanisms may appear to us or to the outside to be dysfunctional and maladaptive. And sometimes they are. But really, they are perceived by the person using them to facilitate survival. Right. So it's important to remember that people aren't always conscious that these activities are in fact coping mechanisms, right? Some examples might include things like self-medicating, reclaiming their sexuality, dissociation, self-harm, anger, aggression, things like that. So I want to shift a little bit and talk about activators. So activators are things that remind someone of a prior trauma, or in some instances can initiate a flashback. You might be familiar with these being called triggers, but people have sort of called for a change in language to be potentially less stigmatizing and to call it, again, activators instead. So activators can be conscious or subconscious. They can involve any or all of the five senses. It could be a smell. It could be a touch in a certain way, a certain word, or even the way a certain word is spoken. So maybe it is the smell of a certain cologne or a certain song that someone experiences while they're in your waiting room or in your lobby, right? Really, because of how personalized each trauma is and each person's activators are, we just may not be able to predict what might initiate an activated response. Now, of course, it should go without saying, but always needs saying, the activators don't only happen for our patients, they can also happen for our providers and our staff. So understanding how common trauma is, we have to assume that those we work with and we ourselves have experienced adversity and potentially trauma and carry that into our own interactions as well. Each of us and each person that we work with may be coming alongside us with activators of their own that they may or may not be aware of. One of our biggest and hardest jobs as providers and as people who care for others is to figure out how to remain regulated in the face of someone who is dysregulated, right? And to figure out how to help calm ourselves and keep ourselves sort of grounded again when we're faced with an activator in our work environment. We'll cover a little bit more about activators in the primary care setting and in health screening specifically in a few slides. So trauma-informed care, now that we've talked a little bit about the health impacts of trauma, we're going to talk about what we can do about it, right? So trauma is a whole person approach to healthcare that acknowledges the impact of trauma on health and is inherently patient-centered. A trauma-informed framework assumes that trauma is pervasive and that medical evaluation and treatment themselves are potentially traumatizing. It emphasizes the need to resist re-traumatization and the creation of new trauma through the healthcare experience. It acknowledges that a patient's life experience will impact their perceptions, how they perceive what is happening to them in the healthcare system and what their perspectives on their engagement with the healthcare system are. It also acknowledges that awareness of these experiences has the potential to improve patient engagement, treatment adherence, health outcomes, and even provider and staff wellness and satisfaction. Now, I want to be very clear that trauma-informed care is not the same as providing trauma-specific services. This means a couple of things. One, it means that disclosure of past traumas is not necessary to provide trauma-informed care, right? Rather, we are moving through this assuming that all people carry past traumas and that all people will benefit from this type of approach. So that's really the foundation of trauma-informed care. And again, it's not asking you to do trauma-intensive therapy, right? For most of us, maybe some of y'all on this call are, but most of us, that's not our background or our skill set or our licensure, right? But we can still apply these techniques to provide a better and trauma-informed experience to our patients. So we utilize SAMHSA's 4 Rs. So that states that a trauma-informed approach is one that realizes the widespread impact of trauma and understands potential paths to recovery. It recognizes the signs and symptoms of trauma in clients, families, staff, and others. It responds by fully integrating knowledge about trauma into policies, procedures, and practices. And finally, as we mentioned, it seeks to actively resist re-traumatization. So I'm about to show just a quick 3-minute video that's a great introduction to trauma-informed care and the impact that adverse childhood events can have on a person's lifetime, as well as sort of a brief overview of what we can do to implement a trauma-informed care approach. It also introduces what is really the key paradigm shift of trauma-informed care. If you take nothing else away from this talk, I hope that you take this paradigm shift away, which is moving your thinking from looking at someone and thinking, what's wrong with you, to looking at someone and thinking, what happened to you?
You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made. Plus, our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
Okay, cool. Just a break from hearing my voice. Hopefully that felt helpful. So due to the ubiquity of trauma and the desire to not create new trauma in any setting, a trauma-informed approach should be viewed through the lens of a universal precautions model. So we can think about this the same way that we in medicine think about bloodborne pathogens. We don't wait for someone's labs to come back to don our gloves, right? We just assume that anyone we care for could have a bloodborne illness, and we treat all patients like this universally. It's not enough to use a trauma-informed approach with just some special subsets of our patients. Like those we know have a history of sexual assault, for example, or for someone's first pelvic exam or something else sensitive like that. It is, again, that full paradigm shift. As you heard in the video, it's moving from judgment to curiosity and compassion, remembering that no one owes us a disclosure. We should assume that everyone has experienced trauma and that all patients may have at least a few ACEs in their lives. This universal precautions model applies to all fields of work, and it also applies to all of our personal interactions as well. There's also the concept of vicarious trauma, which again, in the Learning Collaborative, we spoke about last month, where we engage with empathy with other people's trauma. We can experience some effects of trauma ourselves. So if you think about the way that you interact with the people in your lives, and maybe even take a look at yourselves, think about who around you might be using coping mechanisms. What is it like to shift your perspective after a difficult interaction? And instead of saying, oh, what's wrong with this person, to say, wow, I wonder what happened to this person. How does that shift your interaction, the way that you feel about this person, the way that you feel in your body just moving through the day, right? Okay. So we have covered a lot. Let's take a few minutes and reflect on some of these ideas in our own work environments. So thinking about your own patient populations and specialties, thinking about the histories that you take, the procedures that you do. And I am going to ask that you go ahead and put some thoughts in the chat. Okay, this is the official audience participation part. So I want you to think about, what are some areas in your day-to-day interactions in primary care or in your area that could be a source of trauma for patients? Again, mine are pretty obvious, thinking about pelvic exams, things like that. But what are potential activators in your environment that might remind a patient of a past trauma? Blood draws. Thank you, Elizabeth, for kicking us off. Absolutely. But having students involved in patient care. Yes, learners, extra eyes, extra hands, repeated exams. Absolutely. STI discussions or sexual history taking. Any exam or touching. Yes. Of course, Autumn's commenting on for our LGBTQ youth and trans youth, weight measurement. We are about to talk a bunch about weight measurement. Yes, people being ignored, closed spaces, immunizations, demographic questions. Y'all, this is awesome. Thank you. Childcare, asking about any needs in the home. People can struggle with feeling like they're being judged for needing extra help. Absolutely. We've got someone who said ER patients who've experienced family members' death in the same ER room. And I would say that is true in almost any healthcare environment, right? Driving up to the same building where a loved one had a terminal diagnosis or some kind of significant treatment. Someone echoing the smells or sounds in the lobby prior to the appointment. Department of Health screenings, location of resources. Y'all, these are wonderful, and there are so many potential examples. I really appreciate you all thinking through them and contributing, engaging, and sharing at this level. Thank you. So all of those are fabulous, and we could do like a whole talk on most of them. But I tried to pick a couple that come up often when we talk about this, and you touched on many of them in the chat. So we're going to take a little bit of time and walk through them now. So again, right now we're going to talk about weight and blood pressure, dental exams, thyroid exam, blood draws, and the pelvic exam. Okay, so I'm going to start just by acknowledging the fabulous folks in that picture. The woman having her blood pressure taken is one of my teaching partners and one of our MTITC training faculty, Dr. Alyssa Conklin, who's pictured here with her wonderful, wonderful medical assistant who helps us out often also. So when a patient is called back from waiting room, most offices have them get on a scale and record their weight, as someone mentioned in the chat. They're often asked their height so we can record their BMI. They're often walked into their exam room and their blood pressure is taken first thing. So what kind of traumas might people have surrounding these two very routine healthcare events? So what about patients with a history of an eating disorder? What about folks who just aren't happy with their current weights and they're really not looking for a reminder of it, right? I know people who have chosen not to seek healthcare because they're like, I just don't want to get on that scale, right? And yes, thanks, Sarah, people are touching them during some of these exchanges as well, right? Not to mention that the MA weighing them may announce the weight in the hallway in front of anyone in earshot, right? Feeling constricted by machines, constant criticism of weight in our society, absolutely. So then the patient walks to the exam room, sits down, and the blood pressure is taken right then. You just mentioned, what about that constriction on the cuff, right? What does that feel like? How tight can it get for someone who has a history of physical violence or abuse, right? Does that feel like exactly someone just put in the chat, squeezing arms, right? What about that patient who wants or needs it taken on a certain arm? Are they feeling nervous about that? Do you give them a space to say that? What about those with high blood pressure who know it's not great and just really don't like having their blood pressure taken when they walk right into the room? Or what about that person who doesn't have high blood pressure, but man, were they rushing, right? And they couldn't find a parking spot or they couldn't find the office, and now they're really stressed out. Or maybe someone who's just, they call it white coat syndrome for a reason, right? Someone who is anxious just being in our presence. And now they're starting their visit with a, oh, wow, your blood pressure is really high today comment, right? So there are so many pieces of this that could be activating. So what could we do to get someone's weight and blood pressure in a more trauma-informed way? So for one, we could ask everyone if they want to see or hear the number on the scale. You can see people can turn around, right? We could offer someone to face away from the number if they prefer. Or even more radically, think about, does every patient actually need their weight taken at every visit, right? So many of us do need a certain number of vital signs to meet different standards for our institutions. And of course we need to do that. But does weight need to be one of them, right? We have to think critically about if having a weight will alter the patient's care plan or options in any way, right? Could we offer the patient a choice? Now, depending on your role, you might not know if a weight is needed for today's visit, and that's okay, right? But could we offer that we could get it now, or we could check with the provider to see if it's needed and grab it later if it is? Most of my GYN patients, honestly, don't need a weight for most visits, right? There are of course, exceptions, right? Thinking about efficacy of emergency contraception, right? That is impacted by weight, things like that, or tracking some weight gain in pregnant patients. But even there, do we really need it at every single visit? We probably don't, right? Um, Many people have complicated relationships with their weight and their bodies. And that's not just those with histories of an eating disorder, right? So this style of care can really benefit everyone. Similarly, in many cases, we can ask the patient if they prefer to get their blood pressure checked now at the beginning of the event of the exam or at the end of the visit, right? We could ask them, as someone mentioned, if they have an arm preference, or again, if they want to hear this number once it's taken or not. We can also make sure that we explain that they're going to feel a lot of pressure or constriction as the blood, as the cuff pumps up before we begin, and then we can ask their permission to begin. It's so routine for us, but it may not be and may be difficult for the patient. Okay. So that kind of covers some ideas about trauma-informed taking of vital signs. Let's move on to a dental visit, okay? And some of the FQHCs that are on the call have dental services, so I want to make sure that we're covering that as well. So patients are typically laying down pretty flat on their backs. This can be a vulnerable position, right, in the first place. You have this napkin draped around their neck and often brought kind of right up to their neck. Providers, of course, are leaning over them. Someone mentioned the proximity of providers to patients, right? Obviously, in their personal space in a dental exam, instruments placed in their mouth, making it hard to talk, hard to communicate. There may be discomfort or pain. They may taste their own blood at times. You may have your mouth fill up with water faster than you'd like, which can give a sensation that you're about to choke, all kinds of things. It's easy to imagine how difficult elements of this could be for someone, say, who has experienced strangulation, which is far more common than people think within domestic violence circumstances, especially. Or how about someone who has been sexually assaulted orally, right? Even beyond those very concrete connections, there are so many potential activators here that we've talked about. One example, again, using my colleague, Alyssa, who you saw on the past slide, she just really doesn't like anything touching her neck. It squicks her out. She just hates it. So this piece of the dental visit is really challenging for her, right? So what can we do when it comes to dental exams to make things more trauma-informed? Remembering that no one owes us a disclosure of their trauma, so we're just going to assume that everyone has a history and everyone could benefit from this. Is there anything we can do about the position? Could they lie less than flat? So, of course, this example that you see on the screen is pretty extreme. He's sitting like completely up. But is there something that we could do to make it a little less vulnerable? Could we have the patient place the neck napkin on themselves instead of a staff person doing it for them? That is always something that Alyssa would value greatly, right? So I think about it all the time now. Is there an opportunity to pause more and check in with the patient to see how they're doing? If they need a pause or to say something. What if we were to offer to the patient, hey, I know that you have your mouth full. So if you want to say something, please raise your hand or clap or some other nonverbal cue, right? Could we offer a mirror for those who want to see what's going on? Again, really, it's about choices. Wanting to give the patient an experience where they feel like a member of the team who's doing stuff with them and not just someone who's having stuff done to them. Okay, thinking about the thyroid exam. So kind of enough said with this picture, right? Anyone who's had a history of strangulation is likely going to have a hard time getting through an exam like this. Someone standing over you, behind you, with their hands on your neck, looking at the position, the power dynamics, and again, where those hands are placed. So what can we do better? What about when we think about examining the heart and lungs, right? Some providers sort of snake their stethoscope down the patient's shirt or gown, others listen over the gown, and others expose the skin and listen directly on it. Now, clinically, we know that one of those is better than the others, but it's still a source of vulnerability for the patient. Not to mention that if you're doing a thorough examination of the heart, right, you have to listen at the base of the left breast, right, which can be uncomfortable. What about the abdominal exam, right? There's another sort of routine physical exam thing that can have a lot of vulnerabilities. Is the patient's gown already completely open with their chest exposed at the time of the abdominal exam? Or is it only the abdomen that's intentionally exposed while everything else is covered, right? Do you tell the patient what you're going to do before you touch them, or do you just go for it? Sort of with the assumption that they know what you're going to do next, or that because they're here on their back, here for a physical examination, that they have sort of tacitly consented to each part of the exam, right? So where can we do better? For the thyroid exam, let's try some different positioning, right? You can actually do this exam from the front, right? And learning new things, I know a lot of us learned from the back. Learning new things is always hard, but you can adjust and think about either doing your thyroid assessment from the side or sort of from the front, as you see Alyssa doing here. It's still touching someone's neck, right? You're still going to do a lot of sort of warning and an explanation beforehand, right? And you're still going to wait and say, let me know when you're ready, right? Or is it okay for me to begin now? Tell me when to begin, right? But just this change can make a really big difference. For the heart and lung exam, we can think about this photo, right? What if the patient was able to move their own clothes or gown around to expose what we need for the exam to their comfort level? Go ahead and explain exactly where you need to place or move the stethoscope before you do it. Could the patient even place the stethoscope themselves, right? Lots and lots of options. So then for the abdominal exam, we can make a point to explain exactly what we're going to do. Saying something like, next, I'm going to examine your abdomen. For that, I'm going to expose your belly and use pressure with my hands, right? We're going to go from under your rib cage to the area down by your hips. Is that okay, right? Notice again that last part, getting consent at each point in the exam. So for all physical exams, we're going to explain each step. What places are there in your interaction that you can offer choices? And that you can even offer the patient to put their hand over yours as you do an exam to give them a little more control, which also, by the way, is a tip for patients who are really ticklish, right? So lots of things that you can do to help. Now, someone brought up blood draws, which is always a really important one to consider. So it's such a routine part of healthcare, but something that can cause patients so much anxiety. So needles, blood, discomfort, all of these in and of themselves can be activators. When we think about the concept of consent for something like a blood draw, I always think it's really interesting because patients are agreeing to it, but it is generally something that they really don't want to do very much, right? So they may understand that they need it for whatever reason, but they're saying sort of a burdened yes, right? Not coerced, I wouldn't go that far, but they are consenting to something they don't really want to do, right? And that is just different, okay? And something to just think about. And then what could this remind someone of? Of course, it can bring up ideas around drug use. It can cause cravings for some people. Notice that there was a conscious choice made to not include photos on this slide because we know that for some people, just seeing needles or tourniquets can trigger cravings for some folks, right? Or it could bring up feelings about a family or loved one's drug use. People have even associated blood draws with sort of being activating for sexual assault, because again, it is something entering your body that you don't really want to enter your body that is causing discomfort, okay? So again, where are their choices? We can think about types of needles, right? Can you offer if it can be a butterfly or a straight stick? How about anesthetic spray or those peds distractor things like this? The little like vibrating ice pack that's been shown to help distract from the pain of a needle stick, right? Does the person have a preference of where? There are so many ways that we can provide some choices. Okay, I want to be conscious of time. So listen, the pelvic exam, obvious vulnerabilities. We know that the position is vulnerable, that no one is at their best when they have their pants off, right? And that not only are they undressed, but their genitals are exposed, right? This is clearly a vulnerable position, and they're in front of a stranger, right? There's power dynamics that are inescapable, because really at the end of the day, even if we're known to our patients, we are strangers to them, right? So then we add in the exam itself, which of course shouldn't hurt, but is certainly not comfortable or anyone's favorite way to spend the day, and by its very nature is intimate. So we have to acknowledge again that while much of what we do is completely normal for us, and we may do it dozens of times a day, it's anything but normal for our patients. And we have to own that piece, that there are pieces of what we do in this exam that may mimic things that happen in people's personal, intimate lives, right? Perhaps in consensual sex, or perhaps in non-consensual sexual encounters that they've had in the past. Okay. You can see here some examples of making sure that we're conscious to use non-sexualized language. Okay. We can also think about other pieces, like perhaps you're aware of the recommendation from ACOG that chaperones should be present for every intimate exam, for every genital or breast exam. And for some, this can promote safety, but for others, this policy may be coercive or not trauma-informed. Similarly, Kelly brought up learners, right? How readily do we bring people into the rooms, right? And that while I love students, and of course people have to learn, that can't supersede our patients' needs, their right to decline, their right to not have more eyes or hands on them or multiple exams, okay? So what can we do? Do we need footrests every time, right? Absolutely not. This picture shows that there is plenty of room to place the speculum, even using the table instead of the footrests, right? Some patients may prefer the footrests, and that's fine, right? Especially we find that often with older folks that's a little more comfortable. Whatever it is, it's just about choices, right? So where else can we offer choices to the patient? Can we talk before they're undressed, right? Explain everything that you can well dressed ideally. That may not be possible in every environment, but could be. Do they want to place the speculum themselves, right? Do they want to hold your hand while you place it, or watch with a mirror, right? How about positioning? Again, could we raise the head of the table up a bit to help them feel less vulnerable? How much explanation do they want, right? We often think that it's trauma-informed to explain everything before we do it, and I talk about that all the time, but also some people are like, I don't want to know, it's too much detail, right? So think about what ethically do you need to explain, and then how could you stop talking to let them zone out, play on their phone, be distracted, talk about kids or pets or whatever else, right? Any kind of choices that we can do is really what's empowering for the patient, right? So that's really where it's at, okay? We're not going to spend time on this today. We've talked about the 4 R's, but here are the 6 key principles of a trauma-informed approach, right? Hopefully you've heard some of this before, but bringing in elements of safety, which is both psychological and physical, making sure that you are trustworthy and transparent in all of your encounters with your patients and your colleagues. Peer support, which may be helping to bring together patients who have similar backgrounds or experiences, thinking like an HIV support group or a infant loss support group, things like that, but also thinking about this for ourselves, for our teams. Collaboration, leveling power differences, and working with shared decision-making, and then empowerment, right? Again, shared decision-making, giving choices, helping to do shared goal setting. And then thinking about culture, how can we really lift up and keep in mind that historical trauma that we talked about, avoid cultural stereotypes and biases, and really work to examine our own identities and privileges. So what is consent? Again, we usually think about consent in 2 main contexts, both consent for medical procedures and then sex, right? These are the 2 places where we think about it a lot. This can actually help us, well, it's a little bit uncomfortable. It can help us really think about some norms or common things in healthcare that we really need to examine. So one of the things that I often talk about is if we are in the middle of a procedure and a patient says, stop, how often have you heard someone say, or have you even yourself said, just 1 sec, we're almost done, right? In the context of a medical procedure. Now, if we think about that in a sexual context, if someone said stop and the partner said, just a sec, I'm almost done, we know that that's not okay. And we need to think about that when we think about medical procedures as well. Okay, so we need to think about how are we going to language to know, does a patient just need a pause or have a question? Or are they really saying, no, no, I'm done with this right now and it needs to stop and it's okay with me if the procedure isn't completed, right? So all of that is that sort of pre-talking and pre-conversation with the patient. Also remembering that the absence of a no is not a yes, okay? Patients have a right to decline to informed declination as much as they have a right to informed consent. Okay, so some of this was covered in that video, sort of some initial steps to get started on making your organization more trauma informed. I just always want to highlight this quote from Sandra Bloom, who created the Sanctuary Model, which is a template for system change towards trauma-informed care. And she says, trying to implement trauma-specific practices without first implementing trauma-informed organizational culture change is like throwing seeds on dry land. So hopefully your leadership, wherever you work, is supportive of you being here and being on this trauma-informed journey. If you are here as the champion in your organization, just know that you, of course, can make individual changes that make things better for your patient and your environment, but that it cannot just be on you and on your shoulders. That to be trauma-informed requires a much broader and deeper real culture change, and that's hard within the current culture and landscape of healthcare, right? But we are here to support you on that journey, and I'll leave that there for now, I think. So again, we'll just kind of leave with some quick final points. So we looked at trauma-informed care and principles and ideas that you can put into practice. But one of the things that's always hard is that it's not just a checklist and now, boom, we're trauma-informed, right? So a couple more strategies to operationalize this. Again, not in order or as a prescribed process, but just strategies to keep top of mind. So of course, explaining the steps, what to expect, the rationale, the risks, benefits, and alternatives, which of course calls on those principles of safety and trust and transparency, as well as informed consent, okay? Place and space, thinking again about safety, don't block the door, right? Think about ways to provide and increase comfort. Can you meet a patient when they're dressed, right? Can you make space to wait that is private? What about just asking if now's an okay time for a phone call? How often do we call someone when we have 5 minutes in our day and they may not be in a place that they can talk and we don't even like acknowledge that piece of their humanity? What other comfort items can we provide? Music, fidgets, making it okay to play on their phone during an uncomfortable examination, right? Permission, we cannot assume the right to someone's body or story or even their time. We need to ask. Empowerment and reassurance, we talked about a little bit already, but really looking for your patient's strengths, right? You're brave to be here, right? Instead of looking at someone saying, oh, I see you missed several appointments, saying, I'm so glad that you're here today, right? How about communication preferences? We touched on this a bit. Again, often thinking that we need to tell them everything, but thinking that it's okay if people don't want to hear everything also, right? Trust, we know, is a schema, a cognitive schema that is specifically altered by trauma. So we have to keep that in mind when we're approaching our patients or clients and building relationships. And above all, we need to trust that while we may be the experts in our area of care or in medicine, that the patient is the expert in their own lives, okay? So again, final pearls to wrap up. remembering that universal precautions model that this benefits everyone, right? We don't need a disclosure. We're just going to assume that everyone has a history, your patients, your colleagues, truly everyone you interact with in the world, okay? Again, focusing on that fundamental paradigm shift, not what's wrong with you, but what happened to you, approaching with curiosity and compassion rather than judgment. Then explanation and transparency, thinking about aspects of your work life where you might make assumptions about a patient's consent. Where can you add a little more explanation of a procedure or better explain the why behind a recommendation? Bring them along with you. Where can you pause and absolutely affirm and confirm that you have consent to proceed? Which again brings us to informed consent. The consent process cannot assume a yes. We have to support our patient's autonomy enough to know that an informed declination is also a valid choice. And then ultimately, the best gift you can give a patient is choice. So finding every opportunity to provide choices that may be big or maybe small, but this can make a huge difference in the patient's experience and in building trust in you. Trusting our patients to choose the care path that's right for them and partnering with them in their choices on their care journey. So I have some references for you, and these will all be sent out after the talk. You have my contact information. And then on the next slide, this is a QR code if you would like to get more information on MTITC or follow us for other webinars and other resources and all of those things. I know that we are a bit past 1 o'clock. Are there any questions? Did anything come in the Q&A, Jordan?
I was just about to say, I'm not seeing anything in the Q&A, but definitely feel free, folks, if you have questions, you can put them there or in the chat if that is easier for you.
Yes, everyone will get a certificate of attendance. Jordan will send that out also with the mechanism to get nursing contact hours if needed. Cool. So huge thank you to everyone who joined us. I appreciate the kind comments coming in the chat. Now, if you are not a part of the Indiana Department of Health Learning Collaborative or one of the Indiana local health departments, this is it for now. Also, we can go ahead and stop the recording. If you are part of the Learning Collaborative, Jordan is going to drop